the filtration slit pedicel. This is like a foot-like processes that is wrapping around the glomerular capillaries, and the spaces in between are what we call as the filtration slits. So let me magnify that so you can see it a whole lot better. So we have here, this is the pedicel right here, and those red, pink in color, those are what we call as the filtration slit. All right. Now we're going to move on into the next structure here, which is the podocytes. So they are going to play a role in maintaining the integrity and also the function of the kidney's filtration system. And they are also going to form the part of the filtration barrier in the glomerulus. So that is the role of our podocytes. If there is now, let's say, a cause, let's say a renal failure, it could be the AKI or the CKD or maybe glomerulonephritis, then the structure in the podocyte will be affected, and also the remainder here, which I'll be talking also. And we have here the fenestration glomerular endothelial cell, which is right here. So let's go inside and magnify. So you'll see these tiny holes. And this will actually prevent the filtration of the blood cells, but it will allow all the components of blood plasma to pass through. So it will allow the water, also the electrolytes, glucose, right? Now we're going to move into the next structure here, which is the basement membrane, which is actually one of the main structures that will be affected in the case of glomerulonephritis. So the basement membrane right here, which is this area, which has that blue color, which is the next layer next to the glomerular endothelial cell, this is going to prevent the filtration of the larger proteins. Okay, please take note of that. It will prevent the filtration of the larger proteins such as the albumin, which is the most abundant protein in the plasma, and it will also serve so many functions like maintaining the oncotic pressure. So if you're going to remember about what albumin does to the body, it's actually going to act as like a sponge. Okay, so it will attract the water to stay inside the vascular compartment. It will prevent the leaking of these fluids into the interstitial spaces or the other cavities like the peritoneal space. And so if we are going to encounter problems that say a low albumin, what's going to happen is that most of these patients are going to end up with interstitial edema, right? So you will see them with generalized edema. The fluids are actually not inside the vascular compartment. They are in the interstitial spaces. So you will see these people with maybe periorbital edema or facial edema or dependent edema in the lower extremities, maybe sacral edema, or the third spacing in some of the patients that we have in like liver problems. They're going to have that ascites. So they are those people with the low albumin level in their system. So in this case, back to the basement membrane, it's supposed to prevent the filtration of the albumin. It will not allow it to leak into the Bowman's capsule, and it will not allow the albumin supposedly to be released into the urine. But in glomerulonephritis, the function of the basement membrane, rather, is actually affected, and so it will now cause the leaking of the albumin. Now, another a protein that is categorized as a larger protein, supposedly it will also not allow the immunoglobulin. So these antibodies, they are actually the Y-shaped proteins that are produced by the immune system, and they are tasked to recognize and also neutralize the pathogens such as bacteria and also viruses. Now we also have the fibrinogen, which is another large protein, and this kind is actually going to play a role in blood clotting and also convert it into the fibrin during the clotting process. And another is the hemoglobin, of course. So this is something that we can find in the blood cells, and they are responsible for transporting the oxygen from the lungs into the tissues. So again, remember those types of large proteins that should not be leaking, okay? Because of the basement membrane, they should stay inside the endothelium and will be transported back into the systemic circulation. Now let's talk about the slit membrane, which is basically right here. Let me magnify that, which is that layer with the red color, right? So that is the slit membrane between the pedicels. So they are also going to prevent the filtration. Now we're talking about prevention of filtering the medium-sized proteins. And these are your myoglobin, which is actually a protein found in the muscle tissue. And it will also bind and store oxygen for use during muscle contraction. And there's also what we have as transferrin, and this is a protein that is also involved in the transport and delivery of iron in the blood. So, if there is a problem like glomerulonephritis, all those preventive measures by these layers are no longer there. So all those materials, those molecules that I mentioned, will actually leak out into the urine, and that's why we're going to see these manifestations as we go along in our discussion today. So I hope that you're able to get all those basic but critical functions of the different layers inside the glomerulus. All right, now we're going to talk about the classification of the glomerulonephritis, but this time I'm not going to talk about the acute and chronic. That is actually an old classification because nowadays we're actually upgrading that into 5 different classification, and this will encompass those different immune processes and different pathologies, and so they're going to be much more in sync and much clearer as to what really goes on into these different processes. So the first classification that I'll be talking is the immune complex glomerulonephritis, or I'll put that as ICGN, immune complex glomerulonephritis. So this is a classification of the GN. I'll just call it GN to make it short, right? And this is commonly caused by a post-streptococcal infection, and this type of glomerulonephritis actually occur after an infection with group A streptococcus, and this causes conditions like pharyngitis, or your popular strep throat or sore throat, or if it is a streptococcus found in the skin, we call that one as impetigo. That can also lead to glomerulonephritis. Now, if you're going to ask, how does it happen? Well, after the infection, the body will produce the antibodies, and also it will try to fight the bacteria. And these antibodies will combine with the bacterial antigens, and it will now form the immune complexes. Please take note of that. Again, the body will produce the antibodies to fight the bacteria, and the antibodies will now form with the bacterial antigens, and they're going to end up being as an immune complexes. What's bad about that, though, is that they're going to be deposited into the kidneys, and it can lead into the inflammation and damage. But what I'm referring here is actually the glomerulus. So that is the target site where those immune complexes will get deposited. So now think about the degradation, the destruction of the integrity of those membranes that I showed you. All right. Now another cause is the bacterial endocarditis, and this is the infection in the heart valves. So if you're going to ask, how does this happen? Well, the infection can lead to the release of the bacterial antigens into the bloodstream, and the body will produce the antibody against these antigens. And again, it will form immune complexes that will circulate into the systemic circulation, and it will eventually deposit into the kidneys. And once they get deposited into the glomerulus, it will cause inflammation of those tiny, tiny, tiny capillaries. I'm talking about the glomerulus. All right, so I hope that you're able to understand that. Now, another cause is the hepatitis B, C, and HIV. Well, these are chronic viral infection, right? Now, if you're going to ask, how do they happen? Well, These viruses can trigger the production of the antibodies that form immune complexes with the viral antigens. And again, the same pattern. It will cause these complexes to deposit in the kidneys, again, in the glomerulus, and it will lead to glomerulonephritis. Now, aside from all these type of infective processes, we also have autoimmune diseases. So on the top of the list, we have the SLE. We call the systemic lupus erythematosus. So what is this? Well, it is an autoimmune disease where the immune system can attack the body's own tissues. Well, how does this happen though? Well, in the lupus type of nephritis, the body will produce the antibodies against its own nuclear material, like the DNA, right? And so these will form immune complexes as well, and it will deposit into the kidneys, causing inflammation. Now, as you have listened to what I've just said in the previous phrases, they're pretty much the same kind of patterns, right? Even though it's SLE or an infection, they pretty much have the same kind of pattern. The antibodies will form a complex with the antigen and they will settle into the glomerulus. Same thing. Now, another cause here is the IgA or the immunoglobulin A nephropathy, or known as the Buerger's disease. And this is a condition wherein the IgA, which is a type of antibody, will also be deposited in the kidneys. Well, how does this thing happen? Well, it will also follow infections like those in the upper respiratory tract kind of infection, or could also be a gastrointestinal type of infection. And so the immune complexes containing the IgA deposit will go into the kidneys, and the same thing happens. It will lead into the inflammation. Now, we're going to talk about the Henoch-Schönlein purpura, or we call it as the HSP, or this is commonly known as the IgA vasculitis. So what is this? This is a type of vasculitis wherein there is a massive inflammation of the blood vessels. So when you think of inflammation, it's actually kind of like enlarged. The layers of the blood vessels are inflamed. So they have that kind of thickening. There is permeability, the increasing permeability of those layers. So it will allow leaking of those fluids into the tissues. Now, how is this going to happen? Well, similar to the IgA nephropathy, or known as the Buerger's disease, this will involve a much more systemic form of vasculitis. And so this is going to influence, or this can affect the entirety of the blood vessels in the body, and also can lead into immune complexes with the immunoglobulin GA depositing into the kidneys and other organs. So it's not just specific to the kidney, but also the other organs, and it can lead into widespread inflammation. Now, if you're going to ask, what is the onset and the duration of the immune complex type of glomerulonephritis? Well, it's actually going to be either sudden or it could be gradual, because this is going to be dependent upon the underlying cause and also to the response of treatment. So it will be varied according to what disorder the patient has had, okay? And so if it's an infectious type or it could be an autoimmune, it's really going to be variable at this point. Now, if you're going to ask what kind of diagnostic tests or laboratory testing that will be required to pinpoint this type of classification in the end, well, first things first, we're going to have to expect the medical provider will order urinalysis, and this is going to test for the presence of the protein and also the blood in the urine, which are signs of kidney damage. Now remember when I was telling you about the different layers of the glomerulus? Remember the slit membrane, the basement membrane, the endothelial fenestration? See? If you're going to really go into answering the test questions, you really need to go back into the anatomy and physiology so you can recall how these structures can work And so if there is now a problem involved, you really have to analyze too what problems has been caused by this causative agent or whatever the SLE is going to the structure. And so another lab test that we'll be expecting is the serum creatinine. And so it's going to measure the kidney function. We know what the level is. It's somewhere around 0.7, right? Up until 1.1, 1.2, or 1.3 in some textbooks. And here we are talking about elevated creatinine levels. Serum creatinine way probably above 2 or maybe 3. And this is going to indicate that there is now reduction in the kidney function. Now, it doesn't mean that the kidneys have stopped working to filter the creatinine. It still does allow the filtration, but at a slower rate. It's not capable anymore to filter those byproducts, the urea, the creatinine, at the normal pace. So what's going to happen? The body will be overwhelmed by these uremic products because the filtration rate has been reduced. All right? I hope that you understood that. Now, we're also going to talk about the complement levels. So we are talking about a portion of the immune system, and these actually indicate wherein there is lowered complement levels. These indicate that the system has been used up due to the inflammation in the kidneys. All right? So if there is a reduced level of the complement system, that simply means that it has already been used up. It has already been, it ran out of the complement because of the inflammatory processes inside the kidney. Now, another testing here is the ANA, or we call as the anti-nuclear antibody, or the anti-dsDNA, and these are specific testing for lupus. Going back right here, pointing out directly to the SLE. And so, if the levels are high in the blood test, if the ANA or the anti-dsDNA are elevated, well, this simply means that there are now increasing antibodies suggesting that there is an ongoing systemic lupus erythematosus. All right. Now, if you're going to ask, what is the anti-dsDNA? This is something that we're not really familiar about, right? And so the anti-dsDNA, it's actually standing for anti-double-stranded DNA antibodies. So they are a type of autoantibodies that are produced by the immune system that are specific. They are going to target the double-stranded DNA, which is a molecule found within the cell nucleus. And with the levels of the anti-dsDNA elevated, this is also going to correlate that there is an ongoing SLE. So if there is, again, a high level of a anti-dsDNA, well, again, it means that there is a flare-up, an ongoing SLE. Well, if there is a drop in the anti-dsDNA, it simply means that the person is having a good response to the treatment. Okay? So that's the significance about the anti-dsDNA. Now, another testing here is the ASO titer, which is the anti-streptolysin O, which is very common. And this is a test that will detect the antibodies produced by the body against the streptococcal infection. Now, if it's elevated, well, it's going to help you tell that there is really a recent streptococcal infection. Now, please take note, guys, that the ASO titer will only be diagnostic. It will confirm to diagnose the immune complex type of glomerulonephritis. However, it will not be used in the other classifications that I'll be talking into the next slides. Okay, please take note of that. The ASO titer will only be applicable to this classification. Now, we're going to talk about the renal biopsy. So what is this? This is going to involve getting a small tissue from the kidney, of course, going to be done in surgical technique, and this is going to be examined under the microscope. So what can be shown or can be found under the microscope is that it's going to show some immune complex deposits. There's also going to be inflammation and specific patterns of the glomerular injury. And so the renal biopsy is the diagnostic tool to confirm the type of pathogens, or let's say the causative agents into each classification. But there's something right here, the renal biopsy will be used in all 5 classifications. Okay, again, but not the ASO titer, because this is only specific to streptococcal infection. Now we're going to move into the next classification here, which is the posse-immune GN. Okay, so when you are going to encounter the word posse, this is actually what we term as few or little, because in Latin it actually means few or little. And this is going to be another classification that will tell us that there is some kind of an autoimmune type of process that is affecting the kidneys. Now, the causes for this, or the cause is known to be the anti-neutrophil cytoplasmic antibodies, or known as the ANCA, or I'll just call it ANCA. And this is associated vasculitis. So again, that's anti-neutrophil cytoplasmic antibodies associated vasculitis. Quite a long name. So I'll just call it ANCA associated vasculitis. Now, this is a autoimmune type of glomerulonephritis that can happen when the body system or the immune system goes a little bit into a haywire, and it will start attacking the kidneys. All right, and the attack is linked to a group of conditions called the ANCA associated vasculitis, and the immune system makes something called an anti-neutrophil cytoplasmic antibodies, and this will end up causing trouble, and it will damage the blood vessels, including inside the kidneys. So actually, this is an autoimmune disorder that does not affect the kidney blood vessels, the glomerulus, but also the other organs in the body. Now, what is the onset and duration of this classification? Well, this is something that can happen so fast. It is going to be progressive, which is a huge concern because it doesn't waste any time. And because of this, it's very important that we need to catch it as early and treat it quickly to avoid serious kidney damage. So to compare it with the first classification, this is much worse according to the onset, because it can cause the damage to the kidney much faster. All right. Now, what are the diagnostic tests that will be involved into this kind of classification? Well, the same thing. We're going to expect order of maybe urinalysis. Again, this will check for the protein, the blood, and also it will always show that there will be presence of protein. Hyperproteinuria, okay? And so with the hematuria as well. So it will have some similarity with the first classification. Now, the second testing here is the serum creatinine, which is also going to be elevated, which simply means that their kidneys are no longer filtering the waste from the blood as they should, correct? And so the next diagnostic test here is what we call as the ANCA antibodies, and these are the specific names here. So this are your PR3 ANCA or the MPO ANCA. I don't want you to memorize this, but we'll just look into the ANCA antibodies. Now, this will indicate that the immune system is actually going after the kidneys. So when this is elevated in the lab result, that simply means that the kidneys are being attacked already by the antibodies. Now, again, tissue biopsy of the kidney will be involved here, and it will show crescents, which is actually an accumulation of the cells in the glomeruli. So this is what your keyword is: formation or appearance of crescents, accumulation of dead cells in the glomeruli. Now, They're actually a bunch of little cells, and again, a sign that the immune system is causing a lot of trouble inside the kidneys. Now, we also have the third classification, which is the anti-glomerular basement membrane glomerulonephritis, or we'll just call this the GBM-GN. Okay? Now, I want you to picture right now the glomerular basement membrane, which is the third layer in between the slits and also the endothelial fenestration. And again, remember the glomerular basement membrane, they're responsible to prevent filtration of the large proteins like the albumin, right? Remember? Okay, I want you to remember that. The albumin is supposedly prevented by the basement membrane from leaking. But now, the basement membrane is the portion where the pathology is attacking actually this section of the capillary. And so this is something that is closely associated with this disorder, which is the Goodpasture syndrome. I hope that you're familiar with this one. And so here, in the anti-GBM glomerulonephritis, it happens when the immune system will start attacking the specific part of the kidneys, which is basically the glomerular basement membrane. And in the Goodpasture syndrome, the immune system will make antibodies that mistakenly can target the basement membrane. Instead of attacking the source, it will now attack the third or the middle layer of the glomerulus. And so it will cause damage to the kidney. And what do you expect? Instead of preventing filtering those albumin and other large proteins, it will now allow those proteins to leak out. So the person will end up with hypoalbuminemia, right? The body will run out of the albumin because it's leaking from the body. It's being allowed to escape from the glomerular basement membrane. Now, again, the patient will end up with the edema because of the low albumin level. Remember, I told you that this acts like a sponge. It attracts water into the vascular compartment. But with the hypoalbuminemia, the fluids will now start to leak into the interstitial spaces. That's why some people will have periorbital edema, generalized edema, and dependent edema in the lower extremities. Now, let's talk about the onset of the antiglomerular basement membrane GN. So the onset here, it's either acute or it could be chronic severe. Actually, it will only be acute, right? Not chronic. So this is something that will actually gonna need immediate attention as well. And for the laboratory testing, this will include the urinalysis, wherein again we're gonna look for the proteins, the blood, and again they're gonna show up those things. There will be proteinuria, hematuria. The creatinine level is also expected to rise because of the decreased ability of the kidneys to filter out the creatinine. And we also have the antiglomerular basement membrane antibodies. So the laboratory testing will look for those antibodies in the blood that's actually targeting the glomerular basement membrane. Okay? And this will confirm that the patient has this classification of GBM. Now, after that, we're going to have to expect about the renal biopsy, which is also gonna confirm the diagnosis, and it will show linear deposition of those antibodies along the glomerular basement membrane. So, comparing the two here, with the post-immune GN, you'll see the crescents. But here in the anti-GBM, what you're going to see are those linear deposition of the antibodies. Okay? So, I want you to kind of differentiate those two. Okay? Now, it simply means that the antibodies here are sticking to the glomerular basement membrane in a straight line. That's why they have that linear deposition characteristic. Okay. Now moving into the next classification, which is the fourth one, we have the monoclonal IgGN. Monoclonal, which is actually a kind of antibody, immunoglobulin, and this is gonna happen when there is going to be an abnormal production and also the buildup of the specific antibody we call the monoclonal immunoglobulin inside the kidney. So this is going to be associated with like multiple myeloma, which is a form of cancer that will actually cause abnormal plasma cells in the bone marrow. And it's going to allow the production of excessive amounts of the monoclonal immunoglobulin, which will end up depositing inside the glomerulus in the kidneys, right? So it is associated with multiple myeloma. Now, another case that is associated with that is the Waldenström's syndrome. We call this the Waldenström macroglobulinemia. So this is another kind of cancer where the abnormal white blood cells will produce excessive amounts of specific immunoglobulin called the IgM, immunoglobulin M, and these are gonna also collect inside the kidneys. All right. Now, what is the onset and duration of the monoclonal IgGN? Well, here it can vary. Okay, so it can vary from one person or one patient to the next. But some of people may share the same kind of symptoms suddenly, while probably others will have a much more gradual onset. Now, the duration here of the monoclonal IgGN, it will depend on the underlying cause and also how it is being managed. And so again, it is variable. Now for the diagnostic test, we're going to repeat the same ones. We have the urinalysis. Again, it will show proteinuria, hematuria. I'm talking about the red blood cells showing in the urine and also the creatinine level elevating. So expect that the kidney function is already impaired. Again, the rate of filtration by the glomerulus is impaired. So it will cause buildup of the creatinine in the bloodstream. Now, we also have the serum protein electrophoresis, or known as the SPEP, or I'll just call it the SPEP. This test will actually separate the different types of the proteins in the blood, and eventually it can detect the abnormal levels of the monoclonal immunoglobulin. Okay? Now, this will indicate conditions, maybe if it's a multiple myeloma, or let's say a Waldenström's macroglobulinemia. That's quite a tongue twister. Now, we're going to talk about the tissue biopsy, which is one of the mainstays in the confirmation of the diagnosis. And so again, a small tissue, kidney tissue, will be obtained surgically, and it will actually show deposition of the monoclonal immunoglobulins and also nodular glomerulosclerosis. So we are talking about the narrowing of the capillaries, those glomerulus. They're very tiny, they're microscopic. And so there is what we call a sclerosis. Those glomeruli are actually what do you call this? The size of the lumen is narrowed. So what do you expect if there is narrowing of the lumen? Well, it's going to not be able to function well as far as the filtration. And part of that would be some kind of like scarred section inside the glomerulus. So it's not really going to allow proper filtration. That's why we are expecting elevation of the creatinine level. Now, we also have the last one, which is what we call as the C3, glomerulopathy. So C3 actually stands for complement 3, okay? So this is going to cause some dysregulation. There will be impairment in its function, wherein it's affecting the complement system. And this is going to affect mainly the C3 complement system. And this is caused by some genetic mutation, especially, and this can lead into an ongoing, and it will become a much more persistent activation and also deposition of the C3 in the kidneys. Okay, so that's the main problem here. Because of the genetic mutation, it will cause the persistent activation of the complement system, specifically the C3, and this will now get deposited inside the kidneys, and again resulting into the inflammation and damage of the glomerulus. Now, what is the onset and duration of the C3 glomerulopathy? Well, it can either be acute or chronic, meaning it can happen suddenly or could be gradual over time. Now, it's also going to depend on the different factors, including maybe the underlying cause and how it's being managed. Now, for the diagnostic test here, the same top 3 or top 2 lab tests will be ordered, like urinalysis, again detecting protein in the urine, and also hematuria. There will be presence of red blood cells, and that will indicate that there is already kidney damage. And also there's going to be creatinine elevation, and again, if that is elevated, that simply means that the filtration by the glomerulus is already impaired. It is not capable in filtering at a good rate. So now it will start to accumulate in the bloodstream, causing uremia. Now, since we're talking about the C3 complement, we are going to check on the levels of the C3, and it will now indicate that there is a dysregulation of the complement system. So there will be low C3 level. Now, again, tissue biopsy, as I have said, it will be the confirmatory diagnostic test on all the 5 classification. It will show that there is predominant complement 3 in the glomerulus, and it will be seeing minimal or no immunoglobulin deposits, okay? Because that would only be in the monoclonal IgGN, okay? So again, this is only gonna look for a huge number deposits of the C3 in the glomerulus. Now to recap, again, we're gonna start with the immune complex glomerulonephritis, or we call it the ICGN. This will occur within the immune system, which is going to produce the immune complexes, and this is going to be deposited in the glomeruli, causing the inflammation and also the kidney damage. And we are going to associate the first class into the post-infectious type of streptococcal type of infection. So the impetigo, strep throat, those kind of things, and also the SLE. So please don't forget that. That's the first type immune complex glomerulonephritis. And the second one, we have the antiglomerular basement membrane. Now go back to your memory. We are going to imagine about the middle layer of the glomerulus, the basement membrane, which is the target of the antibodies. So this will now cause inflammation and damage to that layer. So expect that there is now leaking of the large molecules, okay? The larger proteins, and all much more with the moderate sized proteins. So pretty much we are wasting the moderate sized proteins and also the larger proteins. Now the third one is we have the pauci-immune, and this is characterized by the absence or paucity of the immune deposits in the glomeruli. So it is going to be associated by the ANCA. Okay? I want you to recall the vasculitis. Okay? So the fourth one is actually the monoclonal IgGN. So this is the type of that Ig, or the type of glomerulonephritis that will cause the deposition of those antibodies, the immunoglobulins, into the glomeruli, causing the inflammation as well. So when we are looking into the tissue biopsy or the kidney biopsy, we will be seeing those immunoglobulins depositing into the glomerulus. And lastly, we have the C3 glomerulopathy. This is involving the genetic mutation, and there is also dysregulation of the complement or C3, and this is going to detect, the testing here will detect the deposition of the C3 into the glomerulus, okay? And all of these classifications will gonna cause the inflammation of the glomerulus and will cause the destruction of the renal parenchyma. The same effects. The mechanisms are quite different. That's why there was a need for me to present it in 5 classification, not just mixing them in just acute or chronic. So this way it will be much better understood. Now, we're going to talk about now the expected manifestations or clinical findings of the glomerulonephritis. So one of the common reports that you will hear from the patient is the anorexia and also the nausea and vomiting, right? And so these are the topmost reports, which is actually caused by the buildup of the waste products in the blood, the uremia. Because the kidneys are no longer able to filter those uremic toxins, and they're going to upset the stomach and also will reduce the appetite. Since we know that it can cross the blood-brain barrier, right? It will cause that anorexia, and the person will also have nausea and vomiting. Well, the person will also complain of painful urination or dysuria, and accompanied by a reduction in the urine output. And so we are expecting oliguria, okay? And the patient will having some hard time in voiding. And the reason for that is because the kidneys are inflamed. Think about the glomerulus or the glomeruli. Not just one, but there's the entirety of the kidneys, right? Both right and the left side. And so imagine the kidneys are inflamed because of the attack into the glomeruli, the small capillaries. So the entire kidney is actually inflamed. And so it will now cause discomfort, and it will now reduce the urine output. And so it's gonna make the kidneys really hard to filter the urine, and it will lead to those symptoms that I just mentioned. Now, another is fatigue. The patient will be easily fatigued. They get so tired even with just a few bouts of walking or jogging. No, they cannot really tolerate this because, again, the body is not able to properly remove the waste. I'm talking about the kidneys and the toxins with that impaired kidney function. And also, it is coupled with anemia. All right? This is also going to impair the ability of the kidney to produce the what? Erythropoietin, right? That is the peptide or hormone that is produced by the kidney to trigger the red bone marrow to produce the red blood cells. But here, it is expected that it's not doing well. It's not going to produce enough of that. And so there will be anemia, and the person will probably get easily short breath, and also they get so tired easily because of the lack of the oxygen supply to the body. Now, another is high blood pressure, hypertension. Well, again, think about the kidney. Remember in our anatomy and physiology discussion, the kidneys play a huge role in regulating the blood pressure. Remember about the renin-angiotensin-aldosterone mechanism, plus the regulation of the sodium, plus the regulation of the potassium. I want you to go back into those 3 concepts that I mentioned. Go back to those, or else you're going to miss in analyzing the pathophysiology. And so at this point, with the glomerulonephritis, the person will not be able to, the body will not be able to really do its compensations through those mechanisms, and it will end up with the hypertension. Now, we're going to talk about breathing difficulties here. So the patient will manifest some shortness of breathing. There will be some lung crackles when you are auscultating. You've got to have to listen to the lung sounds. This is very important, guys. When you're doing your bedside assessment, make sure that you take your time listening to both the anterior posterior chest walls, right? Not just putting the diaphragm for like 5 seconds and then shifting to the next. That's bogus. Not do that, okay? You really have to carefully listen for those different lung fields from the posterior and also the anterior side and lateral aspect, so you can appreciate if there is some crackles going on, if there are signs of fluid overload. And so the reason for that, when the lungs gonna manifest these crackles, or yes, this simply means that the kidneys cannot effectively remove the excess fluid efficiently, and they're gonna end up accumulating into the lungs, and it will now lead to difficulty of breathing issues. The patient will not be able to tolerate supine position. That's a big red flag, right? When the patient cannot breathe easily when they are laying flat in bed, something is not right. If they can only tolerate sitting upright on a chair, or maybe doing that orthopnic position, they have to lean forward on the bedside table or onto the chair, they're going to have to lean forward. That is a red flag. And so that could possibly be a sign that there is pulmonary edema. Now, another is S3 sound, which is actually an extra abnormal heart sound, which indicates heart failure. And so at this point, the body, especially the heart, has been overloaded over time, or maybe the patient may have a pre-existing heart failure, but this is going to be aggravated when the glomerulonephritis occur, because again, there is accumulation of the fluid in the vascular system. Then it can trigger the weakening of the ventricle. And so if there is also a large volume, it will lead problems, let's say backflow into the pulmonary circulation. And that's why you will hear those pulmonary, those crackles, wheezing maybe, the hypoxemia, rapid breathing, and what else? Since we're talking about HF here, you can also see some jugular venous distension, but I did not put it there. Now, again, we're going to move into another manifestation here, which is mild anemia. Well, again, this is because there is a reduction in the production of the erythropoietin, which is the hormone that is supposedly going to stimulate the bone, but it's not doing that anymore. And so there is less production of the red blood cells, and so the person will end up with mild anemia, and this can also contribute to the patient's fatigue and weakness. Now for the edema. Edema is never a good sign. It can be found probably in the legs, could be facial type of edema, or it could be anasarca or generalized edema. And this is gonna happen because the fluid is already leaking into the blood vessels, into the surrounding tissue. And what's the reason why the fluid is leaking? Well, first and foremost, remember about the albumin being reduced. There is no more sponge to keep the fluids inside the vascular compartment. That is one reason. Now, another reason is because of the increasing volume, because of the problem with the protein. There's also that increasing hydrostatic pressure, and that is why the blood or the fluid will be leaking into the surrounding tissue. Now, another is the encephalopathy, wherein the person will have issues with their cognitive function, their alertness will be affected, and this is because there is crossing of those uremic toxins into the brain, and this is going to cause them to be disoriented, and they are going to end up with some neurologic symptoms. Okay, and it can vary from one patient to the next. If the uremia is much more severe, we'll expect that there will be probably onset of seizures, right? But for those probably with milder form of uremia, their BUN or urea level is probably not that high, then maybe they're going to be confused. But you really have to watch for the changes or the progression of their manifestations when you're going to encounter a person with encephalopathy. Now, next to that is the flank pain. Why there is some flank pain in the patient with glomerulonephritis. Why? Well, Again, the kidneys are inflamed, right? And so the two kidneys were actually on the right and left side. And so with that inflammation, it will be felt to the backside, the costovertebral angle, the CVA. Now, another manifestation is the weight gain. I am not happy for that weight gain. We don't want weight gain, right? And so weight gain basically gonna give us an idea that there is now accumulation of the fluid inside the body, not in the vascular compartment, but into the interstitial spaces because of the low albumin. And so we need to make sure to weigh our patient daily when they're in the hospital for this kind of condition, okay? And we really need to do this very religiously, especially if our patient has an accompanying congestive heart failure wherein their oxygenation is compromised. And that is a huge problem. The ABCs here will come into play. Airway, breathing, circulation. And NCLEX would really like to test us on our ability to think correctly, how to prioritize these problems. And so you really need to make sure we are tracking the weight of our patient on a daily basis. Every morning after they voided, same type of weighing scale, same type of clothing, and after the patient has voided to get an accurate measurement. Alrighty, now we're going to talk about the increased or any signs of congestive heart failure. Well, I've said that already, especially it doesn't really matter, even if it's a right-sided or a left-sided heart failure, you will still need to do your daily weighing. And of course, this is a renal problem. We need to make sure we have daily readings of the patient's weight so we can compare if there is weight gain or if the patient is responding to the treatment. Now, another manifestation here is the increasing blood urea, nitrogen, and creatinine. And these are the two waste products that should be filtered by the kidneys. But then again, these two will elevate when there is glomerulonephritis because the rate of filtration has been impaired. Now, the next one is hypoalbuminemia, the main actor here. Hypoalbuminemia, and the reason for that, it is because the basement membrane is now dysfunctional. It is now allowing the large molecule albumin to leak out from that layer into the urine. So the body is actually wasting tons of the albumin. And this is going to cause a whole lot of changes inside the body. Now, another is urinary changes. What are these urinary changes that we are going to see in a patient? Well, these are going to be the hematuria and also excessive foam. Have you seen this kind of urine output in a patient with a renal failure or a person with a glomerulonephritis? Have you seen this one? Like a foamy, brownish colored urine. It's like one of those frothy iced tea, cola colored urine. So that simply means when there is an excessive foam in the urine, that actually means that there's a whole lot of protein in that urine, okay? And so this is again caused by the escape of the albumin from the basement membrane. So if you are imagining about a frothy urine, think about high protein levels in that urine. That's not good. The body is doing it's not working. It's just not working. And even myself, I've had a urine study in the past, and one of the comments that the lab scientist told me, like, what's going on with you? Why is your protein high? Well, yeah, I was taking a medication that could potentially cause an elevation of the protein, which is the ACE inhibitor. And so that was the reason that I had, but I did have that kind of frothy type of urine. So I want you to really kind of operate and synthesize your knowledge so you can apply this in the NCLEX question. So I really want you to focus into the manifestations, the urinary changes, the hypoalbuminemia, the elevation of the creatinine and the BUN, the heart failure manifestations, the weight gain, and it's just hard to miss any of this. I mean, I don't want to miss. I want that all. I don't want my patients to have all the manifestations, but when you are taking a test, I don't want to miss any of these manifestations. I want to look for them. And so that's how I answer the test questions. I don't really look for the answer. I try to eliminate them one by one. If this manifestation coincides with the scenario, I'll get rid of them. So now, please take note, guys, that for the older population that you might be taking care of, they will show symptoms of much more of the congestive heart failure. It's because their cardiac function, their myocardium is not that great anymore, and so they're going to be really at risk to developing circulatory overload and also the CHF. So yeah, that's so unfortunate. Now we're going to talk this time about the laboratory testing, and maybe some of these testing will probably mirror to what I have said already. And so one of those is, again, urine changes. And so there will be hematuria. There's also going to be proteinuria, which is a big deal. So the protein leaking into the urine, which amounts to 2 to 8 grams per day. Imagine that. That is a lot of protein being lost. So what do you expect in this patient? They're going to be malnourished. Okay? Our patients' immune system will be affected because not just the albumin is leaking, but also the immunoglobulins, right? And so they're really going to be prone to developing opportunistic infection with edema as well because of the proteins being lost. Now, we're also going to talk about the high urine-specific gravity. Remember, when you are going to refer to a specific gravity of the urine, if it is low in the value, it simply means that the urine is very diluted. If the specific gravity value is high, that simply means that the kidneys are trying to concentrate. You have a concentrated urine. Now, in glomerulonephritis, there is high urine-specific gravity, and that is showing that there is concentration of the urine because of the reduction in the output. Now, another key here is that the patient will have lower glomerular filtration rate. Remember about the GFR that I mentioned during the first day? Our cutoff for a normal is 90, right? mLs per minute, right? So if you have a patient with the glomerulonephritis, it is expected that it will be much lower than the 90. And so it will give us a hint that the kidney's filtration rate has been quite reduced, okay? And so here we're gonna also expect some orders, let's say blood cultures maybe, or skin culture, or culture from the throat, because maybe if your patient had the immune complex type of glomerulonephritis, we have to find out if there is an infection going on, or maybe a recent infection. It could be impetigo, or it could be the strep throat infection. That's why we can collect the throat swab, right? In order for us to tell if there is a preceding respiratory infection, and also the cultures in the blood. This is something that we need to collect. Now, we're also going to be expecting the medical provider to order 24-hour urine protein collection. Now, I'm going to ask you guys, have you done the procedure in the real patient, collecting the 24-hour urine? Maybe at least 4 hours of her shift, or maybe 8 hours. Have you participated doing that kind of procedure? Yeah? If not, then I want you to really go in depth with that kind of procedure, because that is one of the procedures that will probably be asked in the NCLEX, and you're really going to be tested in if you are able to collect the sample correctly. Well, so the procedure goes like this. Once you get the order from the physician to collect a 24-hour urine collection. What you're going to instruct the patient is to make sure, let's say if it's in the hospital setting, what you're going to do here is to make sure that the the patient's bathroom has the container, right? That's one of those big jugs, like those thick, non-transparent containers. And so you're going to provide a bucket with ice in order for you to ice the outside container. And so by the time when the patient is ready to collect their urine, all those samples will be placed in that big container until the test is completed. And so what you're going to instruct to the patient is to, you're actually going to start the time of the collection. So for example, it's, what time is it? 1:18 in the afternoon, Eastern time. And so let's just put it as like 1 p.m. So you're going to indicate, all right, that we're going to start this collection. So when the patient will be urinating, okay, so for example, they are peeing, that first urine will not be collected, okay? That will be discarded into the toilet, right? What we're going to do with that is we're only going to measure how much that urine is. We're not going to put that into the container. So with that first void, we're going to start the time of the collection. So let's say they urinated at 1 p.m. So that will be your start time. And then by the time they're going to go to the bathroom again, they need to use that specific urinal and make sure that they're not wasting even a drop. So all those urine volume should be collected and placed into the container, okay? And make sure that this is going to be iced. They should report to the nurse, hey, my ice bucket here is running out of the ice cubes. And so make sure that that is going to be replaced by the nurse aide or the nurse. So up until the next day, 1 p.m. in the afternoon tomorrow. So that will be the end time. So you're gonna definitely put a label into the container that this is the start time and this is the stop time. And then immediately you're gonna send that to the lab with, of course, the correct identifiers, the patient's name, and also your initials, and also the laboratory slip. So that is how we're gonna do the 24-hour urine collection. So at this point, what is the reason why we're doing that procedure? Well, with this type of urine collection, it will give us a much better, clear picture. The excretion of the kidneys, the rate of excretion of the protein into the urine, okay? And you will be expecting that there will be massive amounts of protein leaked into the urine. Again, picture out about the frothy urine. It's cola colored and it has some form of hematuria in it. So think about that. Now, you're not really gonna expect a whole lot of urine output at this time since there is already a impairment in the filtration system. So you will expect some form of oliguria for this patient especially, but it can vary. Maybe the form of glomerulonephritis is still in the mild stages or it's not really that severe. And so maybe they have a little bit of like a low cutoff kind of volume. And so that's something that you need to anticipate. Now another is the elevation of the ASO titer. And this is again related to your classification 1, which is the immune complex glomerulonephritis. Increased ASO titer, already mentioned about that. So this is specific into those patients that had a recent streptococcal infection. It could be a respiratory streptococcal infection. You can do the swabbing in the throat, or if it is a skin type of streptococcal infection, which is impetigo, then you're gonna do that swab through the skin as well. Now, we're going to also expect that there will be decreased C3 complement levels, which simply means that this is associated to the third or the other classification, which is the C3 glomerulopathy classification, which is the fifth one, right? So there will be a reduction of the C3 level in the blood because what is going on? The C3 are all inside the glomerulus. They congregated there. They're deposited in the glomerulus. They're hiding inside the kidney structures or in the parenchyma. Now we're also going to talk about the presence of cryoglobulin. So what is this? This is a test that is closely related to the immune complex, glomerulonephritis, and also with that, this will detect the antibodies that's produced in response to the group A beta hemolytic streptococcus, or the GABs. Okay, so this will be also actually the cryoglobulins are going to be seen in the testing because they are going to be abnormal proteins that can precipitate in the colder temperatures. Okay, so cryo means freezing, right? Cold temperature. And so again, the cryoglobulins are abnormal proteins that you can expect to precipitate in the cold temperatures. And they are going to indicate that there is an ongoing inflammatory or an autoimmune disorder that has contributed to the glomerulonephritis. So what you're going to see here in the lab test is that the result will show you presence of abnormal proteins called cryoglobulins in the blood, and this will form the complexes, and these complexes will also precipitate into the small blood vessels, the glomerulus, not just the kidneys, but also the other blood vessels in the organs. Now, we also have positive anti-nuclear antibody or ANA testing, and this is going to be this will signify that there is presence of antibodies that are targeting the body's own cells, and this is common to the immune complex G, and especially in the case of lupus erythematosus. Okay, so think about the first class, and then we also have to expect possible electrolyte imbalances. So don't be shocked because you will really see hyperkalemia. And remember, the kidneys are also responsible in excreting the excess potassium, right, in the normal physiology. So at this point, the potassium ions will really be enjoying because nobody is strict about them. They can enjoy, they can party in the bloodstream because no one's going to regulate them anymore. So that is the scare in glomerulonephritis. There will be increasing potassium ions in the bloodstream, and this can potentially cause problems in your heart rhythm, ventricular dysrhythmias, for one. Now, same thing with the phosphorus. There will be elevation of the phosphate level, and this is going to be toxic in the system as well, but you're going to also expect that there will be low calcium because there is dysfunctional production of the vitamin D, and remember, vitamin D is supposed to what? Absorb the what? Calcium. So expect hypocalcemia because the vitamin D production is not there anymore. Now at this point, we're going to talk about kidney biopsy, and this is one of those confirmatory tests that you should expect to show all those like crescent material, all those that the antibodies precipitating into the glomerulus. And so the kidney biopsy would really confirm the diagnosis, confirm the suspicion, and also assess the prognosis of the patient's status. So if they'll get to see, hey, this is an extensive form of glomerulonephritis, there's already a few remaining functional glomerulus, this is not good. And so this will also guide the medical provider in planning the treatment, and because again, this will reveal the extent, the severity, and also the kind of damage the glomerulonephritis has done. And it will also, again, it will help the entirety of the treatment plan. Now, moving into the next section of our discussion here will be the nursing actions. So your role here as nurses will be paramount. So our goal here for this patient is to conserve the patient's energy at this point because they are easily exhausted. They get so easily fatigued Again, the reason for that is because of the uremia. Another is the low hemoglobin, the low red blood cell. They are going to be exhausted. And we don't want to use up all that energy because it will cause more problems. If we're going to force them to get up and do exercise, we're not supposed to do that. Now, at this point, we're going to have to think about the fluid restriction. So, how are we going to establish this? Well, this is something that the medical provider will have to decide on. And so we really need to consult with a medical provider as soon, or let's say if the patient has been probably in your care for probably a few days now, or let's say 2 to 3 days, if there's any change in their fluid status, then this is something that you need to communicate with the medical provider, especially if there is poor or there is progression in their kidney problem. If the patient really will go into the end-stage renal disease, well, you really need to consult to the physician in order for you to properly manage the fluid intake of your patient. Now, another is the administration of antibiotics, and the reason for that is because some of our patients probably will have some current infections, or maybe, yes, that is because the reason we are going to treat the infection, especially streptococcal type, and the antibiotics will have to be necessary to eliminate those causative bacteria in order for us to prevent more kidney damage and to promote recovery. And so we want to make sure that the patient will have to adhere to the treatment plan as well. Now, another is relaxation technique. This is really going to lessen the stress because stress itself can worsen the blood pressure and also the overall health. So we can incorporate here all the relaxation techniques, deep breathing, meditation, guided imagery. These can be incorporated into the care, into the plan, in order for us to have a much better blood pressure control. Now we're also going to take a look into the respiratory status, and again, it is closely related to the fluid volume circulating inside the body. So at this point, if you have a patient with a fluid volume overload, you have to anticipate possible pulmonary edema, where there is excessive fluid accumulation in the lungs that can cause breathing difficulties. And you want to make sure that you are monitoring your patient's respiratory status, capture those early signs of respiratory distress. Even a slight increment in their respiratory rate is very significant. Don't just say, it's still within normal limits, it's only 21, but yesterday it was 16 and 17. Those are the type of nurses that I hate. I'm sorry, but you really need to pay attention to the trends of your vital signs here so we can capture those problems ahead of time. So make sure that you look into the subtle changes, the rate of the pulse, and also the respiratory rate. If there is a significant rise, let's say from one shift to the next, there is an increment of 1 or 2 or 3, that's something already. Now, also we're going to have to monitor the fluids and electrolytes of the patients in order for us to track if there is retention, if there is, let's say, hyperkalemia, hyperphosphatemia, and we want to make sure that we are notifying the medical provider right away if they get to that certain level that needs attention. We want to make sure that we have to address those before it can cause some problems in their hemodynamics. Now, we're also going to talk about the monitoring of the daily weight. Very simple procedure, but it can really save your patient's life if you're doing this diligently. Yeah, I'm doing my own patient's daily weight when I was back in the bedside. If they're busy dealing with another patient, then I have to do it. And so I can have a better control. I have direct information that, hey, something is not really right with my patient right now. So you have that direct information right away. And this would really stay in your mind throughout your shift if you're doing this yourself. And this is something that is much more helpful rather than depending on some other people to do it. And this can be delayed and can also delay the treatment plan. Now, another thing is the diet. So here we're going to think about the protein restriction, especially if there is oliguria. So if there is now a decreasing amount of urine output, less than 30 cc's an hour, so maybe it's only 15 cc an hour or 20, that is already oliguria. And so if it's severe form, maybe only 100 mLs in 8 hours, that is very significant, right? And so the kidneys are actually not able to excrete the protein waste products. And so this time we really need to notify the physician about this, because there is a plan possibly that we are going to restrict the protein intake in order to prevent more buildup of the byproducts of the protein. So it will lighten the kidneys' workload if we're going to limit their protein intake. All right, I hope that you were able to get that. Now, another is protein intake of at least 40 to 60 grams per day. And this is only going to be implemented if there is no oliguria. So let's say the patient's urinary output is on the normal borderline low, okay, maybe 30 cc's an hour. So that is not quite so concerning, but you still need to keep an eye on. So we can allow the patient to consume that amount of protein per day. And this is going to be needed as well, because we need some protein for tissue repair and also maintenance without overwhelming the kidneys with the waste products. And so our patient's diet could be composed of maybe milk, some eggs, meat. These food items are actually recommended because they can provide all the essential amino acids. So please don't forget that, because diet can also be asked in the NCLEX. Now, another is high carbohydrate diet, and this can also be adjusted if the patient probably has diabetes mellitus. But for those patients probably that does not have the DM, then a high carbohydrate diet is recommended, because this is going to provide them some good source of energy, and this will prevent the body from breaking down more protein. And where does the body break these protein? Well, of course, the muscles. And that's not a good thing. When the body is not getting enough carbohydrates, they're gonna resort into breaking down the muscle stores. And that's gonna cause some more burden into the kidneys, okay? So that is why that's gonna be included in the care plan, high carbohydrate, in order to provide energy. Now, another is protein restriction, potassium restriction rather, not protein, but potassium restriction. As we know, that potassium, again, has no more regulator, there's no more highway patrol watching over him, and so they're gonna enjoy, hey, nobody is looking at us, we can speed up in the highway at 200 miles an hour. Yeah, because the kidney function is already impaired. And so we're definitely gonna do some restriction in the potassium, because the kidney is no longer able to excrete the potassium properly. And so again, hyperkalemia is very dangerous to the heart. We're going to anticipate possible cardiac dysrhythmia, ventricular dysrhythmia. All right, now we're going to look for the sodium restriction as well. So this is going to be restricted if there is hypertension. And so sad that most of the patients with the glomerulonephritis will definitely have some form of hypertension. And we know that sodium already will cause the body to retain more water and can also increase the blood pressure. And so again, there is a need for us to limit the sodium intake, and will help manage the hypertension. But we're also going to base the sodium restriction on the sodium level in the daily basis. So if their sodium level is on the low side, let's say 130, 125, well, that would need some action, right? We don't want to really restrict the patient from getting sodium if they are already hyponatremic. We're only going to restrict sodium intake if their sodium level in their blood is high. We don't want it too high, because it can cause that, it can add more problems, such as in the case of hypertension. And so this is going to be based on the daily serum sodium results. Now another is fluid restriction. Why? Because we are gonna have to um, base our replacement, the intake, based on the insensible fluid loss. And this will also help us to prevent the fluid overload in our patient and to also to prevent the complications. So we're going to have to properly calculate the fluid replacement based on the insensible losses. Those lost through the skin, lost through the respiration, and to ensure that the patient receives enough fluids to stay hydrated, because we don't want our patient to be dehydrated as well. We just don't want to overburden the kidneys if you're not going to use your brain in managing the fluid intake of your patient. So you gotta keep an eye. And so I have a tip as well. If you're going to become nurses in the future, always keep an eye on your patient, especially if they're placed on fluid restriction, because if they don't know the need to adhere to that plan, they're probably gonna steal some water from the bathroom faucet, even though it's not really potable drinking water. They're gonna get some water from the shower if there's no more pitcher water served in their bedroom. And so yeah, you can keep an eye on them, because some of these patients would really sneak into the bathroom and get those as drinking water. Another is that we're going to expect administration of medications such as antibiotics like penicillin or erythromycin or azithromycin, and these are known to fight off the streptococcal type of infection. And so expect these medication, and also keep in mind that these medications need to be adjusted as well according, I'm talking about the dose, and this is going to be weight-based as well, and also based on the creatinine clearance. Now, also expect about the antihypertensives, because with the hypertension that the patient is manifesting, we really need to manage that in order to prevent complications. All right, I hope that you're able to understand those points. Now, at this time, we're going to have to talk about the client education, which is a big deal. You will be asking the NCLEX on how well you're going to be able to teach your patient, especially teaching them about medication instructions or continuous care at home. How are they going to manage or take their medication through the schedule? How are they going to prevent these manifestations from happening? So you are going to keep in mind that this is not something that you need to neglect. So pay attention. Now, we are going to talk about the patient education, including that they need to complete the full course of the antibiotics. If they're going to be fortunate to be discharged from the hospital because they're getting better, and so they need to continue their care at home, if they're able to manage it at home with the use of the antibiotics, then make sure that they need to adhere. Make sure that they're going to complete the full course of the antibiotics, because if not, then the underlying infectious microorganism will not be eradicated. And so at this point, you need to emphasize this. Another thing is we're going to have to monitor and also make sure that they monitor rather, and they need to report their weight changes to the provider. So this is something that would really save their lives at home, because if they're not keeping an eye on their weight every day, then maybe they're already overloaded, right? Weight gain is not a good thing. And so as we know that glomerulonephritis can cause fluid retention, edema, and also weight gain. So this is going to really be a lifesaver for these people. Now we're going to talk about following the recommended or ordered dietary and fluid restrictions. So we're going to make sure that they understand why we are going to place some restrictions in their diet, especially with the glomerulonephritis, in order that they can manage their symptoms better and reduce the strain on the kidneys. Now again, I'm talking about the protein intake, because too much protein can overwhelm the kidneys. The kidneys cannot do the job in filtering the byproducts of protein. All right? So, another thing that we need to do here is to teach them about basic infection control and also hand hygiene, which is very important. As we know that the glomerulonephritis, it's something that is triggered or exacerbated by the infections. So hand hygiene is very important. Make sure that the family members are also encouraged to do it, and also the caregiver at home, right? Because some of these people probably are not washing their hands. Maybe they're only washing their hands if they're only using the bathroom. So make sure you emphasize these things. Now, another thing is, we are going to start with assessing your knowledge here. And so at this point, we're going to answer this question. So we're going to go through the scenario here. This says a 23-year-old male patient is admitted to the hospital presenting with dark urine, fever, and flank pain. After diagnostic test, the patient is diagnosed with acute glomerulonephritis. So what health history factor is most likely to be present in this patient's case? Is it A, history of renal calculi? Is it B, previous renal trauma? Or is it C, recent episode of sore throat? Or D, family history of acute glomerulonephritis? Again, the question is, a 23-year-old male patient is admitted to the hospital presenting with dark urine, fever, and flank pain. After diagnostic test, the patient is diagnosed with acute glomerulonephritis. What health history factor is most likely to be present in this patient's case? Is it A, B, C, or D? I want you to take your pick right now. All right, time is up. So we're going to go through the options here. We're going to tackle the first item. But before that, we're going to have to go into the scenario. So our patient is an adult, 23-year-old male patient, and now is presenting with a dark urine, fever, flank pain, and now there is an established diagnosis of glomerulonephritis already. It's an acute. So which health history is most likely to be present in the patient's case? So basically what the question is asking is, what medical history is associated with this condition? So is it A? Is it the urinary calculi or renal calculi? So let's go through each one here. So when you're going to talk about the history of renal calculi, this is something that is not related with acute glomerulonephritis, because typically it does not directly result from renal calculi or kidney stones. When you're going to review this video, did I mention about renal calculi in all the 5 classification? No, we did not talk about that calculi. Renal calculi is of a different entity and it's not related to glomerulonephritis. There is no mention about any other problems in this option. Make it, eradicate that one. Now let's go to section or option number 2. Previous renal trauma. What do you think about that, renal trauma? So basically what it pertains is that it could be there has been a damage, kidney damage, and could be a potentially kidney-related complication. But this is not actually a causative factor for acute glomerulonephritis. So think again that acute, or let's say glomerulonephritis itself, is associated with infections, could be the autoimmune diseases or other systemic conditions rather than trauma. We never talked about trauma as the risk factors to developing glomerulonephritis. Eliminate that. Now let's tackle letter C. What is letter C? Recent episode of sore throat. Now, I want you to recall that what I said about glomerulonephritis, it could be associated after an infectious streptococcal infection, right? So it could be in the form of a sore throat or pharyngitis, or it could be in an impetigo. And so at this point, the body is actually causing the immune system to react to the infection. And so this again will cause that complex. The antibody will form a complex together with the antigen, and this will load up into the glomerulus and can cause inflammation into that glomerulus, I should say, or glomeruli. So, possibly correct answer. Now let's go through letter D. Family history of acute glomerulonephritis. Kind of tricky, right? There's already a word acute glomerulonephritis. But did I say something about family history as a risk to developing glomerulonephritis? I don't think so. Even though if that is a family history, which could be a significant piece of information, but does one family member that has a glomerulonephritis, does this gonna be an infectious type of disease that could be contagious to this person? No. And so this is not gonna be this is not the correct mechanism of the infection. It does not relate to the glomerulonephritis itself. And so think about the history of the patient. So the patient himself or herself should have a recent infection, such as a streptococcal infection, rather than an infection by another family member or maybe the parent. Okay, so we're gonna eliminate that one. So our test taking skill here is to actually eliminate the unwanted or the distractors here, those options that are not related to the glomerulonephritis. So we already know that renal calculi is not a risk. Same thing with the renal trauma and also with letter D. They are unlikely to be associated with glomerulonephritis. So we only have one option that is quite a strong contender, right? And so aside from that test-taking strategy, we're also going to have to recall the pathophysiology of glomerulonephritis, right? And so we have to recall those factors that are commonly associated with it, and we want to make sure that we have the correct understanding about how the pathology or the pathogenesis of the process here. And so we want to make sure that we're able to identify the most likely health history factor. Now, another test-taking skill here is to reflect on the clinical presentation of the patient. So going back into the scenario, flank pain, fever, dark urine, okay? And so in this case, those I mentioned are actually gonna go alongside with the most relevant health history. And so again, go back into that piece of information. Now we're going to go into the next question here, which is basically before undergoing kidney transplantation with a living donor, what crucial pre-op assessment must be conducted? Again, the question says, before undergoing kidney transplantation with a living donor, what crucial pre-op assessment must be conducted? Is it A, evaluation of urine output, or is it B, observing for indications of graft rejection, or is it C, recognition of signs and symptoms of rejection, and D, assessing the patient's support system and understanding of lifestyle modifications? So which of these options is the correct answer? Okay, I hope that you have picked the correct answer. All right, time is up. So we're going to go through the options here. So, letter A, evaluation of urine output. Now, again, go back to the question. What are we talking about? Crucial pre-op assessment. This is what you are wanting to identify at this moment. What crucial pre-op assessment needs to be conducted? Is it evaluation of urine output? Is it something that is of utmost importance during a pre-op assessment? Well, the evaluation of the output is important in kidney function, right? But it is not most crucial pre-op assessment before the transplantation with a living donor. It can be a priority later on, but not at this moment, okay? Now, what about letter B? Observing for indications of graft rejection. What do you think? Well, I know it's very important that the patient should know what signs they're gonna report to the nurse or the doctor if they are gonna develop some graft rejection signs. But again, we are dealing with the pre-op assessment. It's not the pre-op, one of those priority tasks that we need to do at this point. And so it is going to focus on ensuring the patient is prepared for the transplant surgery and also that they're able to understand the implication of the procedure. So we're going to eliminate B. What about letter C? Recognition of signs and symptoms of rejection. So those are quite similar options actually. And so it's similar to choice B. And again, recognizing the signs of rejection is very important post-op. However, during the pre-op assessment, we are going to focus here on preparing and ensuring that the patient has the necessary support and also if they have an understanding about the lifestyle modification for the post-transplant care. And letter D, what do we have here? Assessing the patient support system and understanding of lifestyle modification. Seems like it, a correct answer. And so what is the rationale here? Well, before the patient undergoes the kidney transplantation with a living donor, the priority here is to assess the patient support system and also if they're able to understand the kind of modifications that they need to do at home as far as the diet, their activity, for so many reasons, because we need to identify if they have this. If not, I doubt that they would be able to help themselves at home. So psychosocial support is a big deal, especially that the transplantation already is a very complex procedure that will require a lifelong commitment, and this will need them to adhere to the recommendations as far as the diet, the activity, adhering to the medication schedule, and definitely the support from the family, also friends, the caregivers, will help the patient to cope with the challenges associated with the transplant process and also the care that they're going to need at home. And so another thing that we need to consider is the compliance with the medication, because after the transplantation of the kidney, they need to adhere to the schedule of the medication regimen, right? Because our goal here is to prevent rejection of the transplanted kidney. And so we have to emphasize again the modification of their lifestyle, make sure that they're gonna be open to changing their diet with the restrictions as well, and also make sure that they show up to their follow-up appointments, because if they're not gonna do that on their scheduled appointments, they're really gonna miss those possible blood testing and new changes in their orders. Maybe there will be some adjustments of the medication dosage, or maybe some adjustment with the treatment plan. And so something that you need to be aware of. Now, also with that, there's a need for us to make sure that the patient is assessed for their counseling as well, make sure that they understand the modifications in order for the care provider to identify any gaps in their knowledge and also to provide them with enough information really that is tailored to the patient's needs. So this can also enhance the patient's participation in managing their condition. So that is the reasoning why we need to have that support system. This is the main priority in the pre-op assessment. Now, again, what is our test taking strategy? Well, we have to really carefully read the scenario. We have to pay close attention to the question stem, and we have to pay attention to the options in order for us to find that distractors, right? And also we're going to have to focus on the pre-op assessment. That is the key word here, pre-op assessment. So our answer here will be addressing the consideration before the transplant surgery takes place, not after, okay? Now, another, we're going to have to eliminate the incorrect option. So we have to rule out those answers that are not directly related to pre-op assessment or does not address the patient's preparation for kidney transplantation. So we are going to eliminate those. Now, at this point, we're going to proceed with the next question here. Question number 3. 2 months after undergoing a kidney transplant, a patient is admitted to the hospital with a diagnosis of acute rejection. So which of the following assessment findings would be anticipated? Again, 2 months after undergoing a kidney transplant, a patient is admitted to the hospital with a diagnosis of acute rejection. Which of the following assessment findings would be anticipated? Is it A, hypotension, B, normothermia? Is it C, reduced white blood cell count? Or D, elevated blood urea, nitrogen, and creatinine levels? So what is your pick here? Okay. So I really want you to pay attention into the scenario. Okay, time is up. So let's go through the question and answer. Again, our scenario about a patient that just had a kidney transplant and there is now an established diagnosis of acute rejection, okay? And this has occurred 2 months after. So I want you to think the concept that I mentioned yesterday about hyperacute, acute, and also the chronic rejection. Remember about the hyperacute, it can happen within the 48-hour period, or let's say week. And then we have the acute, which ranges from about months to years. And then we have the last one, 1 to 2 years, right? And so at this point, it's within the 2-month period. So we are in the acute rejection. So for letter A, hypotension. Is it one of those findings that you would anticipate if there is rejection? Remember what I said yesterday? So hypotension is basically low blood pressure, right? So it's not a typical finding in acute rejection of a transplanted kidney. So what an acute rejection primarily affects is that they are going to cause elevation of the blood pressure because there is fluid retention. The kidney is not working. It's already failing within the second month. And so this will cause retention of the water in the bloodstream. Well, it gives rise to the elevation of the blood pressure. That's why eliminate this one right away. What about letter B? Normothermia, normal temperature. It's not a specific indicator of acute rejection. Eliminate that. That is just a distractor. No bueno. And then we also have that reason for that. It's because in acute rejection, instead of normothermia, our patient will have fever. Remember, they're going to have fever, not normal temperature. So that's why we eliminate that one. So if there is no fever, it will help. If there is no fever, we're gonna have to look for something else. Okay, hypertension, absence of urine output. So we're gonna have to look for other sides. Now, what about reduced white blood cell count? What do you think about that? Is that a sign of rejection? Well, upon my discussion earlier or yesterday, The acute rejection is actually characterized by an immune response. So it will target the transplanted kidney. And so this will result into an inflammation and also elevation of the white blood cell count. So there is now leukocytosis. So reduced white blood count cells is actually leukopenia. So leukocytosis is the correct, or supposedly the correct option. So this is a wrong option. What about letter D? Elevated blood urea nitrogen and creatinine levels. Well, in acute rejection with a transplanted kidney, it occurs when the recipient's immune system will recognize the donor kidney as a foreign body. It will attack right away. Now, it will lead into the inflammation and also damage to the transplanted kidney. And like I have said, it will probably be removed right away. And so at this point, it is expected that the BUN and the creatinine levels will be elevated because there is now accumulation of the waste products. Instead of being filtered, it is now accumulating. So pretty much the same manifestation an ESRD or an end-stage renal disease patient have. And so, yeah, back to where the patient started. Now, what about letter, okay, that's letter D, we're done with that. So our testing strategy here is to really focus onto the expected findings. So we're going to have to consider the physiological changes that are likely to occur in the context of acute rejection of a transplanted kidney. And we want to make sure that we are aligning those concepts that we've learned. Okay, so mainly acute kidney or acute rejection really would affect the kidney function. Just simple as that. So we're going to look for those manifestations that are related to impaired kidney function. Okay, now we're also going to review the pathophysiology that we have learned, think about the underlying mechanism of the acute rejection and how it affects the kidney function, because we know that the BUN and the creatinine levels are indications that there is already an impairment, kidney function. Now let's move on to the next question already. So which nursing intervention is most crucial for a male client in the oliguric phase for acute renal failure? Is it A, limiting fluid intake, or is it B, providing pain relief measures, or is it C, encouraging coughing and deep breathing, or D, promoting carbohydrate intake? Which nursing intervention is most crucial for a male patient in the oliguric phase of acute kidney injury? Is it limiting fluid intake? Is it providing pain relief measures? Or is it C, encouraging coughing and deep breathing? Or D, promoting carbohydrate intake? So let's answer this question. Let's go first with option A, limiting fluid intake. And now our scenario talks about oliguric phase. What do you remember about the oliguric phase in AKI? Remember that it's a sudden or it's an abrupt change in the urinary function. There is no more proper filtration of the waste products and also the fluids. And so the patient now has widespread edema, right? Hypertension, could be uremic. So what do you expect? Limiting fluid intake, would that be a correct one? Well, possibly. Because during the oliguric phase of the acute kidney injury, there is now a significant urine decrease in the urine output. There is oliguria, just the word itself, oliguric phase. The output is less than the normal. And so this will lead to the fluid overload. It can cause problems into the lungs of the patient. There will be hypertension. Another thing is that limiting the oral and intravenous fluid is also important for us to prevent the complication, especially if the patient has heart failure, right, or pulmonary edema. And again, I have to repeat this, that most of our patients that are elderly, having the end-stage renal disease, or actually the AKI, we're talking about AKI here. So if they're elderly people and they are experiencing the AKI, well, their bodies are no longer functioning as they should, and so they're really prone to developing the other comorbidities. And so if they have some issues with their heart in the past, this will really trigger or exacerbation of their heart failure, and this can lead to pulmonary edema, which is its complication. So it follows right after. Now, if we are answering, so A is a possible correct. What about B? Providing pain relief measures. Do we have that information that the patient requires pain relief? No, we don't. Patient is not complaining, and we cannot assume that the patient is complaining either. We don't have that data, or else you're just imagining things. So providing pain relief measures at this point is not a priority because acute renal failure, or AKI, does rarely causes any pain, and it doesn't eliminate this distractor. Let's put an X here. What about letter C, encouraging coughing and deep breathing exercises? So at this point, encouraging the CDB, or coughing and deep breathing exercises, it's very important for the clients with various disorders, but it's not the priority nursing action at this point. It is a good intervention, but it does not place a higher priority. Now for D, promoting carbohydrate intake. Do you think that this will resolve the issue of the oliguria if we're going to give them a lot of carbohydrate containing food items? Maybe it will probably help some, but it doesn't really take priority over the fluid restriction. That's why we're going to eliminate. It doesn't resolve the issue. It does not. Our issue here is that there is fluid retention. The kidneys is not able to get rid of the excess waste products and also the water. So again, our test taking strategy here is to make sure we understand the context of the question. We have to recognize the specific phase of the acute renal failure, which is the oliguric, and we want to make sure that we are providing interventions that will target the manifestations in the oliguric phase, not the diuretic phase, not the recovery phase. Okay? Remember that the oliguric phase is all about significant reduction in the urine output. Now, for the next testing strategy here is to prioritize your intervention. Is this something that would need critical or does it need prompt nursing care? Yes, because the person here with the oliguric phase is prone to developing those fluid volume overload, pulmonary edema, right? So this needs quick action. Now, we're also gonna do the process of elimination for those answers that are not associated. So we're gonna have to eliminate those unrelated nursing options or nursing care. So providing pain relief, it's not a typical symptom of ARF. It's not relevant to the situation. If you had answered encouraging coughing and deep breathing, it's important in respiratory distress, but can you use it to treat the fluid volume overload? No. Okay. You might think that this is important, right? Coughing and deep breathing, but is there an information about distress at this point? No, we don't. What about letter D, promoting carbohydrate intake? Yeah, nutritional support is important as well, but again, it's not as critical as managing fluid balance right now. So make sure that you're prioritizing the physiological needs according to the ABCs, airway, breathing, and circulation. Make sure you do that. And also focus on the life-threatening conditions the patient would have. Okay? So you also need to recognize what actions that can prevent fluid overload in the oliguric phase, and also making sure that you will be able to identify those steps like limiting the fluid intake. All right, let's move on to the next question. After undergoing a hemodialysis session, a client with chronic renal failure requires evaluation to ensure their stability post-treatment. So which of the following standard indicators should the nurse prioritize for assessing the client's condition after dialysis? Is it A, vital signs and weight? Is it B, BUN and creatinine levels? Or is it C, potassium level and weight? Or D, vital signs and BUN? Take your pick. The question states again, after undergoing a hemodialysis session, a client with chronic kidney disease requires evaluation to ensure their stability post-treatment. Which of the following standard indicators should the nurse prioritize for assessing the client's condition after dialysis? Is it A, vital signs and weight, B, BUN and creatinine levels, C, potassium level and weight, and lastly, vital signs and BUN? So let's go through each answer. A, vital signs and weight. It is very important that after the dialysis is done, we need to ascertain that our patient is stable with a vitals reading, right? So we are going to compare the patient's vital signs after the dialysis, compare it with the pre-dialysis and also during the dialysis, and also compare the weight, because we need to know if there is effective fluid removal. So again, basic care. You need to have a dry weight before the patient goes into dialysis. Make sure you have that information readily available, and right after the dialysis, you can also measure the patient's weight. Okay? So if you're thinking about maybe a patient that is very sick, like an old person that is with end-stage renal disease, you're probably imagining that they cannot get out of bed. Yeah, that is quite true. Most of our patients that are on dialysis probably are not as ambulatory as you expect, right? They are probably somewhat kind of obese or maybe very frail, and so they have limited levels or limited ability to move around. That's quite true. So you might be thinking about standing them up into the weighing scale. Well, not really. Our beds in the hospitals have the capability to have that weighing scale, especially the Hillrom beds. You can automatically just press that button. If the bed was already zeroed in, it's easy, just push that button. So it will automatically obtain the weight of the patient, and it will, if you have already put in those, let's say, the linens, the pillows, if those have already been subtracted, then by the time you're going to push that button, it will give you the net weight already. So it's that easy, okay? But if your patient is ambulatory, again, do your diligence, weigh the patient on a standing scale. No problem. It's not a big deal. And so, again, the weighing process is easy, and this is really going to detect if there is effectiveness of the fluid removal. That's very simple. Now let's take a look into, so that is a possible answer. For B, BUN and creatinine levels, what do you think? Well, while laboratory data or studies such as like the BUN and also the creatinine, they are very important nursing actions overall, right, in order for us to determine. But typically, right after the completion of the dialysis, this is not the priority task. Okay, we don't right away check the patient's blood levels to check their electrolytes right after. No, we can check them maybe the next day early in the morning, but not right away after the dialysis. Well, there are some exceptions though. If there is some kind of like metabolic acidosis, or maybe the patient is in a critical care, that's a totally different scenario. But at this point, we're gonna go through the prioritization here. Our first action here is to make sure our patient is hemodynamically stable and also the weight is obtained. What about potassium level and weight? What do you think about letter C? Well, it is also important to monitor the potassium level, also with the weight. But what makes this option wrong is about the potassium level. It's not to be done immediately right after. But what makes it correct, though, half correct, is the weight, but not the potassium. So that's why it's partially correct. Still a wrong answer because we're dealing with a multiple choice. Now for letter D, vital signs and BUN, what is that? Well, the vital signs is half correct. The BUN, again, checking the labs can be done the next day. Um, Same thing with the other options. So it will be half wrong, half correct, considered as incorrect. So we are going to be left out with letter A, vital signs, and weight. Now, the testing skills that we need to have here is to understand the post-dialysis priority. And so our concern here, our main goal here is to recognize the primary concerns immediately after the dialysis. And again, checking the vital signs, the blood pressure, the heart rate, the temperature, the oxygen levels, because this will really capture if the patient is becoming hypotensive. Maybe there is really rapid removal of the fluid, so the patient can become really hypotensive, and it has happened, right? And so these are the things that we need to prioritize at this point, okay? Now, also use the process of elimination. Always do that. And this is my technique that I have been using since my Bachelor's of Science in Nursing degree when I was still in my level 3. I guess I love med-surg. And so I always answer by elimination, and make sure that you're going to have to really use your critical judgment when you're doing the process of elimination. Okay, eliminate those options that do not provide immediate actionable data for a post-dialysis assessment. So again, those labs can wait a little bit while. Maybe it can be done the next day. What we're going to deal here is the stability of the cardiac function and also the hemodynamics. Now we're going to move on to the last question of the day. So for patients who have undergone hemodialysis and have a fistula in their right arm, there is the potential danger of experiencing Steele syndrome, which is a vascular issue that can occur after fistula creation. So the nurse needs to monitor these patients for what signs and symptoms? So we're talking about a patient who has undergone hemodialysis and has a fistula in the right arm. So there is a potential danger of experiencing Steele syndrome, arterial Steele syndrome. So this is a vascular problem that can occur in a patient with a fistula, right? So what is that assessment that you need to monitor for this patient that may have the arterial Steele syndrome? Is it A? Is it pallor, diminished pulse, and pain in the right hand? Or is it B, warmth, redness, and pain in the right hand? Or is it letter C, edema, reddish discoloration of the right arm? Or letter D, aching pain, pallor, and edema in the right arm? I want you to take your pick. All right. Your time is up. Okay. So we're talking about arterial Steele syndrome or Steele syndrome. So basically that is already pertaining to the artery. Okay. So what is this basically? This is a complication that can occur to the distal portion of the patient extremity. So if the fistula has been done in the forearm, let's say, and now the patient is complaining about some circulation problem into the distal part, let's say the left, in this case it's the right arm, right? And so the patient probably has now some problems going on. So what would be this manifestation is going to be like? Is it pallor, diminished pulse? Or is it pain in the right hand? Yes, probably, because these are signs that there is now a reduction in the blood flow to the right hand due to the Steele syndrome. So supposing this is the arm right here. Forgive me, I'll try my best to draw. So supposing that is the patient's arm and the fistula is right here. Okay. So basically when you're talking about arterial Steele syndrome, the problem here is on the distal portion of the patient's arm. So what you can see here will be a reduction in the circulation. So what is going on is that the circulation has been routed into the arterial section of the fistula. So that's why it's stealing blood supply. It's diverting the blood supply into the fistula instead of allowing to circulate the blood into the distal part of the extremity. And so again, this will now be assessed as diminished pulse. So let's say +1, not a good assessment finding. There's also pain and also a decreased capillary refill. So that is one of those manifestations. So if you answered letter B, warmth, redness, and pain in the right hand, what do you think? Well, if you're going to pick warmth and redness, these symptoms actually will indicate inflammation or infection, but are not specific to arterial steal syndrome. And so with the arterial steal syndrome, the affected area will be likely more cold and because of the poor blood supply. And also there will be pain because it is associated with the steal syndrome. So there should be the combination of the warmth and the redness, which is totally going to make the option wrong. What about letter C? Edema and reddish discoloration of the right arm. What about that? Well, edema and reddish discoloration can pertain or it can signify swelling. That could happen in other conditions. So if you're going to think about edema, usually you're going to be entertaining about a venous type of issue. But here we are dealing with an arterial type of problem. So you're going to have to eliminate that. Okay? Now, this is the redness discoloration is something more of an indication that there is some sort of an inflammation or infection, or could be a congestion in the venous circulation. So it's not going to target arterial insufficiency. So again, the edema, the reddish discoloration, they're not gonna signal that the patient has arterial problem. Okay. Letter D, aching pain, pallor, and edema in the right arm. So what is that? Well, if we're going to talk about aching pain and pallor, this can possibly be a symptom of the steal syndrome. However, the edema as an additional manifestation makes it wrong. It's because edema is less specific and it's more associated with a venous issue, like I've said in the previous option of letter C. And so that what makes it a good, or what makes it a wrong option rather, okay? So think about this, edema is not one of those manifestations of arterial steal syndrome, no. So what you're gonna see here again is pallor because of the poor circulation, there is diminishing pulse, and there is the pain in the right hand. So what's the test taking strategy here? You have to recall the condition that is involved, remember about the mechanism of what the problem is, and make sure that you're also identifying the key manifestations of ischemia. Ischemia basically means that there is a lack of blood supply or oxygen supply to the site. So think about diminished pulses, pain, and also decreasing color, pallor, paleness. And we also need to eliminate the irrelevant options. So think about the pathophysiology, rule out those options that describe the symptoms that could be inconsistent with ischemia. So warmth and redness, those are for inflammation and infection, not about arterial steal syndrome. And edema, it's pointing towards a venous type of problem, okay? So that's all about the test questions for this session. And so this time I really want you to grab our offer, especially with the current 90 days of free NCLEX training classes. We're doing this every day at 12 p.m. Eastern time. So invite your friends. If they're busy, encourage them to watch the video after they probably doing some work, so they can still watch the videos, and also make sure that they can do that so they can also get the perks the Q&A, and also we are encouraging about the subscription to the course that we're offering at our website at www.stancoast-nclexcoaching.com, and the description will be cited below. And again, I thank you for your time and also for following this lecture series, and I'll see you again tomorrow for the next topic, and it will be on nephrotic syndrome. So I hope that you're able to learn something about our discussion, and I hope to hear from you soon, especially with your comments in the video. Please share and also drop a thumbs up for us. Thank you and have a great day. Bye-bye.